Welcome back, everyone. Welcome to my channel. Today is a special video. I have a guest all the way from Melbourne, Australia, Dr. Batool. She is online. I'm excited to have her, and we are going to talk about GLPs today. Dr. Batool, do you mind going ahead and just telling everybody about yourself?
Hi everybody, my name is Dr. Albatat and I'm so pleased to be here talking with Dr. Jamal today. So I'm a general practitioner, a family doctor in Melbourne, Australia, and I see a lot of cases, different walks of life that come every day, and I try and help as much as I can.
Well, I am very excited to have her. Dr. Batool is different than I am. As you guys know, I'm a hospitalist, so I practice internal medicine, adults only 18 and above, but primarily in a hospital, like in an inpatient setting. Whereas Dr. Batool's in the clinic, and her expertise is mainly in primary care medicine for my American audience. So let's just jump in, and my first question is for Dr. Batool. So Dr. Batool, patients are often asking me about Ozempic and Mounjaro, and I wanted you to explain to our audience, what are they and how are they different?
Yeah, so look, that's a very important topic, and I see this question mainly like maybe everyday kind of thing. And people mainly come in for asking about weight loss. And before we jump into the medication, we actually go through a very thorough history about like what the patient has actually tried before, what's their diet like, what's their exercise is like, if they have any medical conditions, if they take any medications, anything that can affect their weight. Sometimes we might even need to start to do a blood test before we actually jump into the medications. By this time, I will have discussed all the other different options, but for today's purpose, we're just going to focus on Ozempic and Mounjaro. In Australia, I'm not sure how it is in the UK, but Ozempic is only prescribed for diabetic patients. But now the companies or pharmaceutical companies now made a new brand or new different form, and they call it Wegovy, and works exactly the same thing as Ozempic. But Ozempic we can only prescribe it for diabetes, whereas Wegovy we can prescribe it for weight loss. And then there's also the new medication Mounjaro. They both work as in they mimic the natural hormone called GLP-1, glucagon like peptide 1, which helps increase insulin secretion and decreases glucagon, which gives us better blood control. It slows a stomach empty, where people then feel hunger, like easily feel full for longer. And they also act on appetite centers in the brain, which reduces hunger and craving. So as a result, people who use Ozempic feel lower appetite, smaller portion sizes, and fewer craving, and hence weight loss. Whereas Mounjaro also has works on the GLP-1, but it also works on a different receptor called GLP-1 receptor agonist. So it has a dual effect where people feel have lower appetite and feel fuller for longer. And so they feel less hungry and therefore they start losing the weight.
Okay, well, that's really interesting to know, especially since I know that researchers have been studying this particular hormone and mimics and analogs of that for decades. So it's always interesting for our audience to try to know the mechanisms as to how these medications work and lead to the actual effects that we desire.
That's right. And so, how about you, Dr. Jamal? How do you explain GLP-1s in general to your patients in the hospital? Do you go and explain it the same way, or do you prefer different type of way to explain it to your patients?
Yes. So we have so many hormones, and my patients, I'm not gonna be able to try to delineate like everything and all the details. But what I try to tell my patients is that this particular class of drugs is supposed to mimic a set of hormones that we release when we're eating food to help do all the effects that you described. And in a hospital-based setting, I use these medications more in their roles for how they have helped people with atherosclerotic cardiovascular disease. I know that's a mouthful, you guys, but that is basically blockages, what we call plaques in your arteries, and blockages in the heart, or blockages in the neck, which are blockages in the brain and blockages in the kidneys. And over time, our arteries develop plaques, which we use atherosclerotic cardiovascular disease as a term for. Well, the amazing thing about these particular medications is that they have been shown to have beneficial effects in patients who are diabetic. So in patients who are diabetic and have atherosclerotic cardiovascular disease, they have a reduced risk of fatal and non-fatal MI. They have a reduced risk of fatal and non-fatal stroke. In other areas for my patients, I do get a lot of diabetics who are in here for other things. And while they're in the hospital, we are managing their diabetes. So some of these patients struggle to get that hemoglobin A1C to our goal of 6 to 7. And so what we will do is often we advocate for them to try to use a GLP, which really helps kind of get them down at least 1 to 2 points. We also have patients that have started asking about this for obesity. Before, it was standard practice to refer patients to bariatric surgery, but now not as much because of the advent of these medications. And then finally, it's also been advocated for people who have chronic kidney disease.
Yeah, look, that's exactly what I also try and explain to patients. Thanks for explaining that. And what are the most side effects do you keep an eye on in the hospital, or that the side effects are usually discussed with your patients?
So yes, we are seeing quite a few patients come in that have a GLP as part of their medication list. So the number one side effect that we see in the hospital is gastrointestinal. So what does that mean? We're talking about nausea, vomiting, diarrhea, and constipation. Now, these are dose dependent. So with higher doses, it's more likely to have more of these symptoms or side effects. The problem, though, is that nausea, vomiting, and diarrhea are so common in other diseases that often when patients come in, we have to take a careful history to determine if it's the GLP that caused those particular set of symptoms, or if it's another disease, such as a stomach bug, or a form of a viral illness or food poisoning. Outside of those symptoms, we have seen biliary or gallbladder disease. Pancreatitis is another one. Incredibly rarely have we seen small bowel obstruction. I think one of my colleagues saw one a few months ago. Those are incredibly rare. And then more common than bowel obstruction and biliary disease is gastroparesis, which is delayed gastric emptying. Patients will report complaints of not wanting to eat. And when they try to eat, they don't feel the food goes down, or they just feel full earlier. Families are complaining that the patients are just not eating enough, and they're trying to force feed them, and they're just not able to do it. We do a test in the hospital, and we find out that their stomach has significantly slowed down, where they're hardly eating. Rare side effects include psychiatric. The data is still ongoing about whether or not depression is worsened. There's just not enough evidence to show that there's a strong effect, but there have been some people reporting that. We also have the anesthesia risk because the stomach slows down its digestion. Anesthesiologists are asking for these medications to be held or even paused earlier before their surgery. Other reactions that are rare include angioedema, which is when the lips, the throat, and the tissues inside the neck swell from a severe allergic reaction. There could be some local reactions from the semaglutide injections. Again, it's rare, but those reactions or effects are similar to people who take injections for other medications, such as insulin. And then we've got a few cases of optic neuropathy, which causes blindness. And Europe has released a set of guidelines where any patient who's on a GLP, I believe it was semaglutide, and they experience vision loss, they need to be evaluated immediately, as they should for vision loss, and the semaglutide needs to be stopped. And then finally, there have been some reports about thyroid cancer increasing. There's unknown effects on whether or not the GLPs can affect thyroid cells and cause cancer. So for those individuals who have family members with thyroid cancer or have thyroid cancer themselves, they are not eligible to take GLPs. So, and Dr. Batool, I was curious, so in your practice, I know that Mounjaro is more popular or more utilized in Australia. So patients may be asking you about hair loss. How do you explain the connection between Mounjaro and hair loss?
Yeah. So look, in Australia, we use Mounjaro purely for weight loss in relation to Ozempic. We used to use Ozempic in the past as in a private script, but it was our label. But because now we have Mounjaro, we now focus on Mounjaro and Wegovy for weight loss. Sometimes a lot of patients worry about hair loss. I explain that hair loss isn't directly from the medication itself, but usually from the rapid weight loss and nutritional changes. And then, look, as you said, we usually don't prescribe it for people who have any history of thyroid cancer or anyone with a history of pancreatitis.
And when it comes to the doses, like in your clinic, what do you usually start with, and how do you decide between semaglutide and Mounjaro, and then when do you and your patients begin to notice changes?
Yeah, so look, we usually start with Mounjaro because the studies now show it's more effective for weight loss compared to Ozempic. We usually start with the lowest doses. So it comes, we usually start with a very low dose of 2.5, and then the patient usually stay on the same dose for 4 weeks. It comes in a pen, and the pen has 4 doses, and the pen will last for 4 weeks. So you will need to inject yourself once a week, and ideally the same time. You don't have to be, whether some people worry whether you should have food or, take it before food or after food, it doesn't really matter. But it needs to be once a week, same day each week, so you don't forget. And we usually start with 2.5 and gradually build up, and 5, 7.5, 10, and then it goes to a max dose of 15. I usually tell my patients you don't have to go all the way up to the maximum dose of 15 milligrams. If you are losing weight and you're maintaining the weight, for example, we start on 2.5, then you reach up 7.5 or 10, and you're still losing weight and maintaining the weight loss, you don't have to go all the way to the maximum dose. You can stay on the 10 milligrams and keep going on that dose.
Dr. Batool, what kind of counseling do you provide patients who come seeking weight loss medications?
Yeah, so look, I usually do, like, as I said before, take a full history, what they tried before, if they have any contraindication, if they have any family history, as we said, thyroid cancers, if they have any other medical conditions or risk factors, do they smoke, all those factors come into it before we prescribe any medications. Obviously, the medications, I always say, it's like the icing on the cake. The patient still needs to do and put all the weight in. So diet is really important as well as exercise. Because those medications, we're not aiming to stay on them for life. They are there to help us maintain a healthy lifestyle and get into the habit of good, healthy lifestyle. So the diet, the healthy diet, and the exercise. And usually, sometimes when a patient starts this weight loss journey, that's when we decide whether we need to see a dietitian or refer them to a dietitian, whether they need to see an exercise physiologist and refer them to exercise physiologist before we start the actual medication stuff. Because I always tell patients there is no medication that's safe. Everything has side effects, and that's when we say benefits outweigh risks. So if the patient can do the journey without the medications, that's good. But sometimes their weight or their obesity is bringing them along a lot of complications, that's when we need to give them some help and give them the medication.
Yeah, that diet is always a part of any form of like weight loss program. I keep telling patients that we're going to do our part as doctors. We're going to get you the medicines, but you guys need to participate in your healthcare plan as well, and you do your part. You do the exercise, 50 minutes a day, 5 days a week, you guys, or 30 minutes a day, 5 days a week. But exercising, diet changes. It's challenging for a lot of patients, especially with the rise in food deserts. But it's still pretty much part of the treatment plan. Only medicines can do only so much.
That's completely right. Because once you stop the medication, if you haven't got into the healthy habits in your daily life, you will gain all the weight that you lost again. So there's no point, and we will be starting from zero again.
When it comes to these GLPs for weight loss, is that they remember the 90s where we had quite a few stimulant form of weight loss medications that ended up being very hazardous. And so quite a few patients became scared. But weight loss has always been a strong desire for some time. So, what I tell patients is that these initial studies were not meant for weight loss. The GLPs were studied for diabetes and for blood sugars control. And over time, the research data found that patients who were on GLPs actually sustained their weight loss over a longer period of time compared to placebo and compared to earlier drugs from those earlier times. And one of the major studies that really kind of facilitated this jump into using GLPs and studying them for weight loss was a semaglutide treatment effect in people with obesity program. It's called Step 1. It was published in the very prestigious New England Journal of Medicine back in 2021. And from there on, we've just been studying GLPs for weight loss, and it's not really going to end anytime soon.
That's exactly right. And look, the other thing with the cycle of them, even though they are a great medications, and look, I've seen a lot of amazing results with my patients and their journey since they've been on it compared to when they first started. Obesity or weight is not only affecting as an appearance, it can affect a lot of different things. The complication of obesity can affect the heart, diabetes, high blood pressure, sometimes even type of cancer. And that's why this topic is really important. And whenever I'm opportunistic with my patients, we bring it up and discuss it. But the problem with these medications, even though they are great and they amazing at helping patients, is the cycle, is the cost. I'm not sure how expensive they are in USA, but here in Australia, it starts at $300 and it goes all the way through to 800. So they can be a bit pricey. How is it like in USA?
I believe it starts off at $300 as well. And I think that's been a rate limiting step for some of our patients, especially those who are underinsured. They're not able to afford that. And I don't believe Medicaid covers that either. Medicaid, for those who are watching from Australia and other parts of the world, is a form of government health assistance, but they don't really cover every medication. So it's been challenging for a lot of our patients to be able to even acquire these medications.
Yeah, same here. Like through health insurance, I think for us, they cover only a very small portion, like $40 or something, which is not much compared to medication itself. So yeah, that's another big thing. But look, if you think about obesity and all the complications, and I usually say a lot of patients who can't afford it, that I have a patient who says I actually saving money because I'm not eating fast food every day, and I can spend that amount of money on the medication itself. So
that's a good way to look at it. But I guess nowadays $300 doesn't buy much of fast food anymore either because it's just so expensive.
I know that's right.
Yeah. So, any closing thoughts about just GLPs? Any last messages you'd like to leave our audience with?
Yeah, look, they are amazing and they are very helpful in helping a lot of people lose weight. But diet and exercise, you still need to put in the hard work, unfortunately. And you need that healthy lifestyle to keep the weight off as well.
Yes, I agree. I tell patients when they get to the hospital, they're usually there for acute conditions like a heart attack, stroke, a pneumonia, COPD exacerbation. And while we are treating their primary reason for being in the hospital, we also can't neglect these other things. And usually we'll review these patients' medicines. And I tell people that, look, the damage has already been done by the time you get to me. You already have your heart disease. You already have your lung disease and your strokes, or you have disease on a CT of the brain that suggested higher risk for stroke. And some of these patients have had diabetes for years. So one of the things that we can do as hospitalists that we try to do is we recommend our patients follow with their primary care physicians to ask about these drugs, physicians such as yourself, to inquire about whether or not a GLP is good for you. But ultimately, internal medicine, we are focused on long-term control of these diseases with everyday steps. So I am so happy that you were able to join me in this discussion for my audience. We have a 15-hour time difference, y'all. So it's 9 p.m. her time, around 6 a.m. mine. But, we got to do what we got to do, right? To just spread the message.
Thanks for having me, and I'm looking forward to more health topics we can discuss together.
All right. Thanks again. All right,
See you
later. Bye.